Uganda is facing a diabetes epidemic. One type of diabetes affects only pregnant women. Gestational diabetes mellitus, or GDM, is defined as glucose intolerance with onset of fast recognition during pregnancy. Although around 1 in 10 pregnant women are affected by gestational diabetes, many people are not aware of the severe risks it can pose for both mother and child. Women who are overweight, older, have previously had a large baby, or have a family history of diabetes are more at risk. However, many women who are diagnosed with GDM have no obvious risk factors. If undiagnosed or poorly treated, it can lead to significant health risks for the mother and child, including increased risk of developing type 2 diabetes later in life. As nurses and midwives, you have a key role to play in the diagnosis and management of gestational diabetes. You are ideally placed to inform women about the importance of GDM testing in pregnancy and can provide timely support to women who are diagnosed with GDM.
Usually they are worried about their baby who is in the womb. How will I go about this problem when I'm pregnant? What will I eat? Will I get money to treat myself?
Ideally, all pregnant women in Uganda should be screened for GDM at least once during pregnancy. Women should be first screened as early as possible in the first trimester, preferably at the first antenatal care visit, to rule out pre-existing diabetes. If the first test is negative, women must be tested again between 24 to 28 weeks of pregnancy. Diagnosis of GDM should be via a fasting plasma glucose test or via an oral glucose tolerance test using a 75-gram glucose load. When conducting an oral glucose tolerance test, you should encourage women to slowly consume the sugar drink over 5 to 10 minutes to minimize nausea. Once diagnosed with GDM, initial management should focus on lifestyle changes. Women should be supported to increase physical exercise and follow a balanced meal plan. This advice can be delivered in a group education setting. With gestational diabetes, maintaining a balanced diet is important. Women should be advised to eat smaller portions of healthy food spread over 3 small meals and 3 snacks each day. Light physical activity, such as walking, is also recommended for 30 minutes per day. For many women with GDM, lifestyle changes will be sufficient to keep their blood sugar under control. After a few weeks following a meal and activity plan, women with GDM should have their blood glucose tested again, ideally with a 2-hour postprandial blood sugar test. As a guide, if their blood sugar levels are 120 milligrams per deciliter or more, lifestyle changes are not sufficient to control blood sugar and medical management may be necessary. If the level is less than 120 milligrams per deciliter, the pregnant woman can continue with dietary advice and physical activity only. Women with GDM who are not on medical management should have their blood glucose monitored regularly throughout pregnancy, preferably at least every month.
Fellow health workers should step in the footsteps of these mothers, should feel what these mothers are feeling, should give them enough time to ask questions, because the condition itself, it's new to them. They have little knowledge about it.
If a woman requires medical management, a doctor will prescribe either insulin or metformin. Women who are prescribed insulin may be anxious about injecting themselves. You will need to show them how to do it safely. Women must be advised how to store the insulin and dispose of the needles. Ideally, women on insulin injections should regularly monitor their own blood glucose at home and record the readings. Some women will be prescribed a tablet, metformin, to take each day. Common side effects of metformin include diarrhea, nausea, stomach pain, heartburn, gas, and lactic acidosis. You should reassure women that any side effects are usually temporary. Women with GDM, particularly those on insulin, may experience hypoglycemia, low blood sugar. Women should keep glucose powder or tablets or a sweet food or drink close by at all times, just in case of hypoglycemia. Following a treatment program for GDM can be challenging. Family support is key to making lifestyle changes that can be sustained. Encourage women to bring a family member or friend to appointments. The fetal heart rate should be monitored by auscultation at each visit. Where possible, ultrasounds should be performed to check fetal health and growth. It is generally recommended that women with GDM deliver in hospital, but if blood sugar is well controlled, delivery can take place at the usual health facility. Pregnant women with uncontrolled blood sugar levels or those with additional risk factors should deliver at a hospital. Where the baby is expected to be bigger than 4 kilograms, a cesarean section at 39 weeks is recommended.
Ate n'omukyala bw'amala era okuzaala tumugamba okwongera okulabirira obulungi omwana, okumuyonsa amangu, okumuteeka mangu ku bbeere, okuziyiza embeereza eziyinza okujjawo nga osukaali omutono na obunyogovu obuyitiridde, kubanga okuyonka kutaasa embeera ezo.
Infants of mothers with GDM should be checked for hypoglycemia soon after birth with capillary blood glucose testing conducted via heel puncture. Maternal glucose levels usually return to normal after delivery. Around 6 weeks after the birth, women diagnosed with GDM should have their blood glucose tested again. The use of a 75-gram OGTT, fasting, and 2-hour postprandial is recommended. If a woman's results suggest that she has prediabetes or diabetes, you should refer her to the NCD or diabetes clinic for ongoing management. Women with normal blood sugar levels at 6 weeks will still be at higher risk of type 2 diabetes in later life, and they should be encouraged to follow a healthy lifestyle and have annual monitoring. Uganda is facing an uphill battle with gestational diabetes, but with continued education, testing and treatment, we can all work towards a positive difference for both mother and child.